Good evening. Am I audible and visible? If I'm audible and visible, can I see a thumbs up, please? Good evening, Komal. Yes, you can ask me doubts during the session, for sure. Okay. So, if you're joining the session for the first time, good evening, Abhinandan. If you're joining the session for the first time, this is Dr. Shanmugapriya, you're an Academy educator for Biochemistry. And today it's an FMGE Biochem session for 2 hours. And in this 2 hours, I'll try to complete the entire biochemistry. So I've chosen few high-yield MCQs covering the entire biochemistry, using which I will help you get the confidence to answer any question that is asked in the upcoming FMGE exam. Okay, so before we start the session, let me tell you a few facts about Unacademy's plans. So currently there is a flat 20% off going on all NEET PG store subscription. And for example, the target next batch, duration of this batch is 7 months. The original price is 15,000, but currently it's available at the cost of 9,600. And the target FMG batch, duration of this course is 3 months. Offer price is 4,400 when the actual price is 9,999. And the offer has been extended till 31st May, that is day after tomorrow. And to get this offer, you can use any educator's code. You can use my code, which is C Shanmugapriya. And this is about the target FMG 2023 batch in detail. This is a high yield revision batch for FMG 2023 aspirants, and the duration of this course is 3 months, and totally it would cover 200 plus hours. And all 19 educators of all the subjects will be covering high yield topics. We will be discussing frequently forgotten volatile topics, PYQs. And as I told you, the cost is 4,400. And if you're a NEET PG or next PG aspirant, again we have target next batch, and this is a concise batch with both theory and practice sessions, and duration of this course is 7 months. It would include 200 plus hours, 400 plus hours distributed over 200 classes, and this is available at the cost of 9,600. Good evening, Shafiq. Good evening, Master. Hi, Mr. Medicine. So this is also about the NEET PG Vitals, which includes recorded videos for comprehensive NEET PG preparation. There are totally 800 plus hours of recorded sessions for all 19 subjects. And we've also covered the PYQs and image-based questions. So that's all about Unacademy's offers. Let's start discussing the MCQs. And this is the first MCQ for today. Thiamine acts as a coenzyme for all of the following except. Hi, Paras. Can all of you start answering? Thiamine acts as a coenzyme for all except pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase, trans-ketolase and trans-aldolase. What is the right answer, all of you? The right answer is trans-aldolase. This does not need thiamine. So do you all remember what I've already told you? Thiamine is B1. Yeah, B1 can be remembered as 1 meal a day. Yeah, I told you 1 meal a day is a part of keto diet. What will you use this to remember? If you suspect B1 deficiency, what will you estimate? You will estimate RBC trans-ketolase activity. Right? You will estimate RBC trans-ketolase activity. So trans-ketolases are dependent on thiamine. Very good, all of you. Excellent. Yes. And then pyruvate dehydrogenase complex is dependent on thiamine, and whenever you discuss about PDH complex, you have to include alpha ketoglutarate dehydrogenase complex also in the same list, because both these enzymes resemble each other in every possible way. Okay, so tell me, what are the thiamine dependent enzymes? This everybody should remember. The most important thiamine dependent enzyme is pyruvate dehydrogenase complex, which converts pyruvate into acetyl-CoA. And if you have forgotten this, please don't get confused between pyruvate dehydrogenase and lactate dehydrogenase. What have I told you about lactate dehydrogenase? It converts pyruvate to lactate. Pyruvate dehydrogenase converts pyruvate into acetyl-CoA. The second one is alpha ketoglutarate dehydrogenase complex of citric acid cycle. The third one is branch chain keto acid dehydrogenase enzyme of branch chain amino acid metabolism. And the last one is trans-ketolase of HMP shunt. Okay, so all of you tell me, Delta ratio. I will tell you, Shafiq. After this question, I will tell you definitely about delta ratio. Okay. So what are the enzymes which are dependent on thiamine, all of you? It is PDH complex, alpha ketoglutarate dehydrogenase, branch chain keto acid dehydrogenase of branch chain amino acid metabolism, and trans ketolases. And this is why whenever you suspect thiamine deficiency, what will you estimate? You will estimate RBC trans ketolase activity. And only because of this, whenever branch chain keto acid dehydrogenase is defective, what do you call that condition is? Can anybody answer this? Branch chain keto acid dehydrogenase deficiency causes maple syrup urine disease. And this maple syrup urine disease responds to thiamine administration because the enzyme is dependent on thiamine. Okay? Yeah. So what is the right answer here? It acts as a coenzyme for all except trans-aldolase. So Shafiq has been asking us about delta ratio for a very long time. So let me help him understand delta ratio, and this will be of use to all the others as well. Okay. So listen to this. When will you use delta ratio? The first point about delta ratio is it is used whenever it's a case of high anion gap metabolic acidosis. Do not randomly start calculating delta ratio. When will you calculate delta ratio? Whenever it's a case of high anion gap metabolic acidosis, to find out if there is a hidden normal anion gap metabolic acidosis or if there is a hidden metabolic alkalosis. Do you all understand this? And normally delta ratio, what is delta ratio? It is anion gap minus 12 divided by 24 minus bicarbonate. What is the formula for delta ratio? It's calculated as anion gap minus 12 by 24 minus bicarbonate. And the normal value is anywhere between 1 and 2. Okay. So what if the delta ratio is less than 1? If it's less than 1, it means it's not only a high anion gap metabolic acidosis, there is also a hidden normal anion gap metabolic acidosis. And is this a possibility? Can anybody tell me? Can you see a patient with a mix of high anion gap metabolic acidosis with normal anion gap metabolic acidosis? It is possible, right? For example, the patient can present with diarrhea. Okay, diarrhea causes normal anion gap metabolic acidosis. And a patient of diarrhea who's also a type 2 diabetic individual, because of this infection is presented with diabetic ketoacidosis. And what does ketoacidosis cause? Ketoacidosis causes high anion gap metabolic acidosis. So is it a possibility that you can see your patient with high anion gap metabolic acidosis as well as normal anion gap metabolic acidosis? Yes. When will you see this? Example is a type 2 diabetic individual presenting with a gastrointestinal infection which causes diarrhea, which will result in normal anion gap metabolic acidosis. Because of the infection, there is diabetic ketoacidosis which causes high anion gap metabolic acidosis. But if you're going to just find out anion gap, okay, if you're going to just calculate anion gap, in this individual, anion gap will be in the range of 20. Why is it in the range of 20? Because the patient is suffering from diabetic ketoacidosis. But this has hidden a normal anion gap metabolic acidosis. To find out that hidden component, what should you do whenever you see that the anion gap is high? Start calculating delta ratio. What is the formula for delta ratio? Can you all type it in the chat box? Delta ratio is calculated as anion gap minus 12 by 24 minus bicarbonate. If it's only between 1 and 2, then it is just a high anion gap metabolic acidosis. If it is less than 1, then it is not only a high anion gap metabolic acidosis, there is also a hidden normal anion gap metabolic acidosis. What if it's more than 2? If it's more than 2, it's a combination of high anion gap metabolic acidosis and metabolic alkalosis. Has that answered your question, Shafiq? Yeah. Now do you understand the significance of delta ratio? So this is the next question. Blood glucose at 12 hours post meal is maintained by what? at 12 hours post meal. Till 12 hours, what is a major source of plasma glucose? I told you it is liver glycogenolysis. Okay, so let me tell you what are the ways by which blood glucose can be maintained. There are three ways by which you can maintain blood glucose. One is obviously the dietary glucose. The second one is liver glycogenolysis. Excellent Paras, excellent Gayatri, very good Mr. Medicine, Aman. Yes. So the first way of you maintaining blood glucose is dietary glucose, and the second one is liver glycogenolysis, and the third one is gluconeogenesis. Dietary glucose can maintain blood glucose till 2 to 2.5 hours after the previous meal. Yeah, I think even the last session I told you about this. Suppose you have your breakfast by 8 p.m. till 10 to 10:30 p.m. your dietary glucose will maintain plasma glucose. After which contribution from dietary glucose decreases, but blood glucose cannot be allowed to decline because principal cells of your body, namely neurons and RBCs, are dependent on glucose. So how will you maintain plasma glucose after 2 to 2.5 hours of dietary intake? It is going to be liver glycogenolysis. And do you think this liver glycogenolysis can go on forever? No. It can maintain blood glucose till 12 to 18 hours of starvation. So it starts from 2 to 2.5 hours of the previous meal, and it can maintain blood glucose till 12 to 18 hours, because around that point every glycogen that is stored in the liver of the person gets used up. After which it has to be gluconeogenesis. When does gluconeogenesis begin? It begins 6 hours after the previous meal. Okay, gluconeogenesis begins 6 hours after the previous meal. Though it begins 6 hours after the previous meal, till 12 hours post meal, what is a major source of blood glucose? It is liver glycogenolysis. Okay, so what is the right answer here? 12 hours post meal is maintained by liver glycogenolysis. Can muscle glycogenolysis ever maintain blood glucose, all of you? Muscle glycogenolysis cannot maintain blood glucose because glycogenolysis is done by which enzyme? Glycogenolysis is done by glycogen phosphorylase. And as the name indicates, this enzyme adds inorganic phosphate to the product. What is the product? Glucose. To glucose, when glycogen phosphorylase acts, phosphate gets added. So the product of glycogenolysis is not free glucose, it is glucose 1-phosphate. Please memorize this. What is the immediate product of glycogenolysis? Irrespective of whether it's happening in liver or in muscle, the immediate product of glycogenolysis is glucose 1-phosphate. And this glucose 1-phosphate will be immediately converted to glucose 6-phosphate by a mutase. And this glucose 6-phosphate cannot cross the cell membrane, cannot reach the circulation. Only when glucose 6-phosphatase acts on glucose 6-phosphate, it becomes glucose. Only then it can come out of the cell and can reach the circulation. This glucose 6-phosphatase is absent in muscle. Do you all understand this? Glucose 6-phosphatase is absent in muscle, and that is why muscle glycogenolysis cannot increase blood glucose. Glucose 6-phosphatase is present in liver, that is why liver glycogenolysis can increase blood glucose. So the next fact that I want you all to remember is the immediate product of glycogenolysis is not free glucose, it is glucose 1-phosphate. The third fact is glucose 6-phosphatase is not only an enzyme of gluconeogenesis, it's also an enzyme that is necessary for glycogenolysis to increase the blood glucose. Have you all understood this? Yeah? So answer this please. Blood glucose is maintained by all of the following except. Just now I gave you the answer. Yes, it's maintained by dietary glucose. It's maintained by liver glycogenolysis. It's maintained by gluconeogenesis. What cannot maintain blood glucose? Muscle glycogenolysis cannot maintain blood glucose. Very good Aishwarya, good Nirali. A very simple question. Which is the product of anaerobic glycolysis? Who can answer this? Product of anaerobic glycolysis. So first tell me, what is glycolysis? Glycolysis is a process by which you split a 6-carbon compound called as glucose to form 2 products. And the two products which you get will differ depending upon whether the process occurs aerobically or anaerobically. When the process occurs aerobically, aerobic glycolysis gives you 2 pyruvate and 7 ATPs. Whereas anaerobic glycolysis, very good, excellent. I'm very happy that most of you are answering it right. Good, Komal, Ranu, Paras, Nirali. So aerobic glycolysis gives rise to 2 pyruvate and 7 ATPs. Whereas anaerobic glycolysis gives rise to 2 lactate and 2 ATPs. So tell me, how many ATPs do you get in anaerobic glycolysis? It is 2. Okay. Now, I'm going to fill up this tabular column to help you memorize about energetics related to carbohydrate metabolism. Okay. So aerobic glycolysis, quickly tell me the answer. 1 molecule of glucose gives rise to how many ATPs if it's aerobic glycolysis? It is 7 ATPs. Anaerobic glycolysis gives rise to 2 ATPs. Citric acid cycle, how many ATPs do you get from citric acid cycle? All of you please memorize. In citric acid cycle, you start with acetyl-CoA condensing with oxaloacetate. And when this enters into citric acid cycle, oxaloacetate is regenerated. And both the carbon atoms of acetyl-CoA come out as carbon dioxide. This way you get 10 ATPs. Okay. Now complete oxidation of 1 molecule of glucose will give you 32 ATPs. Okay. So please don't get confused between aerobic glycolysis and complete oxidation. Aerobic glycolysis gives you 7 ATPs. Complete oxidation of 1 molecule of glucose gives you 32 ATPs. Glycogen synthesis. When you synthesize glycogen, for you to add 1 molecule of glucose, yeah, whenever you add 1 molecule of glucose, you end up investing 3 high energy phosphates. Yeah, so please remember, glycogen synthesis, for you to add every molecule of glucose, you have to invest 3 high energy phosphates. Gluconeogenesis, what is that you all? Very good, Mohammed Shazad. So what have you learnt about very good, Paras? So gluconeogenesis is reversal of glycolysis. In glycolysis, you start with glucose, you split it into 2 molecules of pyruvate. So what will you do in gluconeogenesis? You start from 2 molecules of pyruvate, you end in 1 molecule of glucose. And for you to convert 2 molecules of pyruvate to 1 molecule of glucose, you invest 11 high energy phosphates. And that is why gluconeogenesis is an anabolic pathway. Okay, so that's all about the numbers that you need to memorize. Okay, but there is a twist here. These are the numbers that you will get when you start from 1 molecule of glucose, plasma free glucose. But what happens if it's a glucose that is a product of glycogenolysis? What is the product of glycogenolysis? I told you it is not free glucose, it is glucose 1-phosphate. This glucose 1-phosphate becomes glucose 6-phosphate, then it gets into glycolysis, then it enters into citric acid cycle. So which step have you bypassed here? You bypass the hexokinase or glucokinase step that usually invests 1 ATP. That 1 ATP you have conserved. So if it is glycogenolysis glucose, sometimes they can ask you how many ATPs will you get when glycogenolysis glucose enters into aerobic glycolysis. In which case add 1. 8 ATPs for aerobic glycolysis, 3 ATPs for anaerobic glycolysis, 33 ATPs for complete oxidation of 1 molecule of glucose. Clear? So this I would say is so frequently asked. Yeah, in FMGE, I see this MCQ very often, either as a one-liner or as a case-based MCQ. So which of the following enzymes? In starvation, not even water, how to calculate total number of high energy phosphates required to convert 2 molecule of lactate to 1 molecule of glucose. Okay, so if it is from lactate, okay, instead of you starting from pyruvate, if you are starting from lactate, first lactate should be converted to pyruvate. And for lactate to be converted to pyruvate, you will get NADH. Yeah, you will get back NADH, 2 NADH. these two NADH will be equivalent to 5 ATPs. Okay, so previously I said if you start from 2 molecules of pyruvate, you will have to invest 11 high energy phosphates. But we are starting from lactate, you're going to get 5 ATPs. So minus 11 plus 5 will be minus 6 ATPs. So if you start from lactate, it is 6 ATPs. If you start from pyruvate, it is 11 ATPs. Does that answer your question, Komal? And if you're asking when a person is starving, from where will the person get energy? That is obtained from fatty acid oxidation. Yeah, when a person is in starvation, there will be deficiency of glucose, there will be deficiency of fatty acid and amino acid. But your body is more worried about glucose deficiency because the principal cell of your body, namely neurons and RBCs, are dependent only on glucose. So the body forgets about everything else. And to maintain blood glucose, it needs energy. From where will the body get that energy? By oxidizing fatty acid. From where will it get the fatty acid? From peripheral lipolysis. Adipose tissue triacylglycerol will be broken down to give rise to fatty acid. Does that answer your question, Komal? So what is the right answer here? Which of the following enzymes is defective in von Gierke's disease? 6 will be the answer. Yes, Komal. Yes, glucose 6 phosphatase. Von Gierke's disease is type 1 glycogen storage disorder and is caused by the defect of glucose 6 phosphatase. Okay, Apurva, this is not glucose 6 phosphate dehydrogenase. Glucose 6 phosphate dehydrogenase is an enzyme of HMP shunt. So let me write down the differences between glucose 6 phosphatase and glucose 6 phosphate dehydrogenase, because not only Apurva, many students get confused here. Glucose 6 phosphatase is an enzyme of glycogenolysis and gluconeogenesis. Whereas glucose 6 phosphate dehydrogenase is an enzyme of HMP shunt. A defect of glucose 6 phosphatase will cause hypoglycemia. When both glycogenolysis and gluconeogenesis are defective, that will cause hypoglycemia. Whereas when glucose 6 phosphate dehydrogenase is defective, when HMP shunt is defective, NADPH cannot be synthesized. So RBCs will undergo lysis. What will it present as? It will present as hemolytic anemia. Okay, G6PD deficiency presents as hemolytic anemia following exposure to an oxidative stress. Okay, because NADPH is necessary for the RBC to protect itself from oxidative stress. Do you all understand the difference? So now let's learn about all glycogen storage disorders here. So tell me, what is the name of type 1 glycogen storage disorder? Type 1 is von Gierke's disease. All of you please answer this along with me. This we have discussed so many times. Lipolysis will happen after how many days? You don't have to wait for so many days, Aishwarya. Even after 6 hours of starvation, lipolysis begins. And that is the logic behind intermittent fasting. You know, intermittent fasting, the person is expected to starve for prolonged period of time, right? So more than 6 hours fasting by itself would be sufficient enough to bring about peripheral lipolysis. And that is why have you all observed in the morning, early in the morning when you wake up, you see that your abdomen is almost flat. But towards the end of the day, you see that it is a bit bulky, right? So because of peripheral lipolysis, in the morning the weight loss is observed, and then towards the day you build the weight. Okay, there is a confusion understanding diagnostic tests of these disease like maple syrup urine disease. I will tell you about it now. Okay, I'll tell you about that now, Komal. So what is type 1? Type 1 is von Gierke's disease, and which enzyme defect causes von Gierke's disease? Glucose 6 phosphatase. Type 2 is Pompey's. Very good, Apurva. Type 2 is Pompey's disease. And the enzyme that is defective in Pompey's disease is acid maltase. I am very happy that all of you are active in the live chat. So Pompey's disease is caused by the defect of acid maltase or alpha glucosidase. So I always ask you to compare and contrast and learn. If you learn that alpha glucosidase defect causes Pompey's disease, immediately you have to recollect about beta glucosidase defect. So beta glucosidase defect causes what? Gaucher's disease. Yeah, this is again frequently asked. Gaucher's disease is caused by the defect of beta glucosidase or beta glucosyl cerebrosidase. Type 3, which is the third alphabet, all of you. Good evening, Medico. Which is the third alphabet, C. So type 3 is Cory's disease. And Cory's disease, C is followed by D. Cory's disease is caused by the defect of D branching enzyme. Okay. We are done with C and D. So next it is A and B. So what is type 4? Type 4 is Anderson's disease. Anderson's disease is caused by the defect of branching enzyme. Okay, after we are done with filling up this tabular column, I will give you an overview of how these disorders would present, yeah, in a logical way. Okay, so type 4 is Anderson's disease caused by the defect of branching enzyme. Type 5, Roman letter 5 looks like V. You reverse V, write it twice. What is it? It is M. So type 5 is McArdle's disease. M for M, it is caused by the defect of muscle phosphorylase. Okay, McArdle's disease is caused by the defect of muscle phosphorylase. Type 6 is Hirsch's disease. H for H, it is caused by the defect of hepatic phosphorylase enzyme or liver phosphorylase enzyme. Very good. And then type 7, Tarrow's disease. Type 7 is Tarrow's disease caused by the defect of phosphofructokinase 1, the rate limiting enzyme of glycolysis. Okay, so have you memorized the list? Yeah, type 1 is von Gierke's caused by the defect of glucose 6-phosphatase. What do you think will be the presenting feature? Let me write down the presenting feature in green color. I want you to think and tell me. Glucose 6-phosphatase is an enzyme of glycogenolysis and gluconeogenesis, the two pathways which are supposed to maintain blood glucose. When those two pathways are defective, what will it present as? It will present as hypoglycemia. Is that clear? Type 1 is hypoglycemia. Type 2, acid maltase or alpha glucosidase defect. 2% of glycogen that is stored in muscle gets metabolized with the help of acid maltase or alpha glucosidase within the lysosome. So when that enzyme is defective, muscle gets affected. When cardiac muscle gets affected, that will present as cardiomegaly and cardiomyopathy. When cardiac muscle gets affected, it presents as cardiomegaly, cardiomyopathy. When skeletal muscle gets affected, that will present as hypotonia. So how will you memorize this? Pompey's disease, which is the pump of your body. All of you? Pompey's disease, which is the pump of your body? Heart. So in Pompey's disease, what gets affected? Heart gets affected. It presents as cardiomegaly, cardiomyopathy. Okay. Now Cory's disease, debranching enzyme defect. Debranching enzyme, as the name indicates, is an enzyme of glycogenolysis. And it's an enzyme which is common to both liver glycogenolysis and muscle glycogenolysis. Then liver glycogenolysis is affected, that causes hypoglycemia. When muscle glycogenolysis is affected, that will cause exercise intolerance. Yeah, it causes exercise intolerance. So tell me, Cory's disease, what will it present as? When it's a debranching enzyme defect, glycogenolysis is affected. So liver glycogenolysis defect causes hypoglycemia. Muscle glycogenolysis defect causes exercise intolerance. Now Anderson's disease, let me give you a clue to understand about glycogen storage disorders. All these glycogen storage disorders either present with hypoglycemia or they present with exercise intolerance. Okay, sometimes they present with both. Do you understand this? All glycogen storage disorders present with either hypoglycemia or exercise intolerance or with both. Now, what are the conditions which present as hypoglycemia? Hypoglycemia is type 1, type 3, type 6. Okay, type 1, type 3, type 6 will present as what? Hypoglycemia. What are the conditions which present as exercise intolerance? All odd numbers. What are the odd numbers? Type 3, type 5, type 7. Okay, exercise intolerance will be type 3, type 5 and type 7. So what presents with both? Which is common to both hypoglycemia and exercise intolerance? Both will be seen in type 3 as well as in 0. Yeah, this question was asked recently in NEET PG. Both hypoglycemia and exercise intolerance is either type 3 Cory's disease caused by the defect of debranching enzyme, or it is type 0 caused by the defect of glycogen synthase. Yeah, why is it called as type 0? Because glycogen synthase, if that is defective, glycogen is not even synthesized in the liver. Liver does not have glycogen. So it cannot be called as glycogen storage disorder. That's why it's called as glycogen storage disorder type 0. Do you all understand this? I'm going to tell you, Komal. So have you memorized this? So what are the conditions which present with hypoglycemia? Type 1, type 3, type 6. Exercise intolerance, type 3, type 5, type 7. Both will include type 3 and type 0. Neither hypoglycemia nor exercise intolerance will be type 4. Why type 4 presents with neither hypoglycemia nor exercise intolerance? Because type 4 is Anderson's disease caused by the defect of branching enzyme. When branching enzyme is defective, glycogen is synthesized without a branch point. And these branch points provide compactness to glycogen. So in a patient with Anderson's disease, liver synthesizes and stores glycogen without a branch point, which is not compact at all. So liver cells enlarge. So it presents as hepatomegaly. Yeah, what does Anderson's disease present as? Hepatomegaly and liver cirrhosis. Neither is hypoglycemia nor is exercise intolerance. McArdle is type 5. Komal, do you understand this? McArdle is type 5, which presents as exercise intolerance because it's caused by the defect of muscle phosphorylase. Got it? So if you have this mental algorithm in mind, okay, suppose the history says you are asked a case-based MCQ, and the case-based MCQ states that there is a neonate presenting with fasting hypoglycemia and that there is also respiratory difficulty. In the newborn period, skeletal muscle getting affected will present itself as respiratory difficulty. This was exactly asked in the recent NEET PG. So if you see both to be present, it's either type 3 or type 0. Okay. Answer this. 8-month-old infant presents with hypoglycemia. About type 4, Gayatri. Sure. So what is type 4? I told you type 4 is Anderson's disease caused by the defect of branching enzyme. When branching enzyme is defective, liver starts synthesizing glycogen, and this glycogen does not have branch points. And it's a branch point which provides compactness to glycogen. So here liver starts synthesizing glycogen. It stores glycogen without branch point, which is not compact at all. So liver cells enlarge. So what will it present as? It presents as hepatomegaly to start with, that progresses to liver cirrhosis. Answer this please. This is a June 2021 FMGE question. So do you understand the progression of the question? In June 2020 it was a one-liner. Okay, June 2020 it was a one-liner. The very next year, June 2021, the same question is asked as a case-based MCQ. 8-month-old infant presents with hypoglycemia. On examination, hepatomegaly was observed. Blood investigations revealed lactic acidosis, ketosis, xanthomas on the buttocks. What is the most probable enzyme deficiency? If it is hypoglycemia, what are the conditions that you suspect? I said type 1, type 3, type 6. Do you see type 1 here? Yes. What is it? Glucose 6 phosphatase defect. That is one possibility. Type 3 is Cory's disease, debranching enzyme defect. Do you see that here? No. Type 6 is Her's disease, which is caused by the defect of liver phosphorylase. Do you see liver phosphorylase here? No. So what is the right answer, all of you? The right answer is glucose 6 phosphatase. Because what is that you already know about branching enzyme defect? Branching enzyme defect is Anderson's disease. What did I tell you it will present as? Just now I told you it presents as hepatomegaly and liver cirrhosis. Do you see liver cirrhosis here? No. And this does not present with hypoglycemia. Glycogen synthase defect. What did I tell you about glycogen synthase defect? Please keep the chat box active. Synthase defect is type 0. And type C0, I told you, will present with both hypoglycemia and exercise intolerance. Do you see any features relevant to exercise intolerance here? No. Okay. So this is not B. Acid maltase defect is type 2 Pompey's disease. Pompey's disease will present as cardiomegaly, cardiomyopathy and hypotonia. You don't see any of that here. That is why what is the right answer? The right answer is glucose 6 phosphatase defect. But that's not enough, right? You should understand why should a patient with von Gierke's disease present with hypoglycemia, present with hepatomegaly, present with lactic acidosis, ketosis, xanthomas. How many of you want to know it? How many of you want to know why von Gierke's disease presents with lactic acidosis, ketosis and xanthomas? Let me explain that to you. So, I'm already done with this discussion. So, von Gierke's disease is a defect of glucose 6 phosphatase. Very good, Aman Hassan. It's a defect of very good medico. Is good Paras. So, von Gierke's is a defect of glucose 6 phosphatase, which means glucose 6 phosphate cannot be converted to glucose, and that causes hypoglycemia. But apart from that, the glucose 6 phosphate which accumulates will start getting into glycolysis. Then it gets into glycolysis. Initially it forms pyruvate, and these two pyruvate then get converted to acetyl-CoA. And acetyl-CoA is a building block of fatty acid. Please remember, acetyl-CoA is a building block of fatty acid and cholesterol. When two acetyl-CoA molecules condense, you get butyric acid. When two butyric acid combine, you get octanoyl-CoA. When two octanoyl-CoA combine, you get palmitic acid. So acetyl-CoA is a building block of fatty acid and cholesterol. So in this condition, there is excess fatty acid and cholesterol synthesis. Fatty acid will be stored as triacylglycerol. Cholesterol will be stored as cholesterol ester. And that is why you see hypertriglyceridemia in von Gierke's disease. And this triglyceride accumulates in organs, causing organomegaly. That is why von Gierke's disease will present with hepatomegaly, renomegaly. Okay. Cholesterol ester is the reason for xanthomas. Cholesterol ester is the reason for xanthomas. And only because there is hypertriglyceridemia, the child will present with chubby cheeks. And that is why the classical term doll-like faces. Okay. Suppose you are given a case-based MCQ. And the case history says that there is a child, newborn, born with a doll-like faces with lots of fat in the cheek. It means it is probably von Gierke's disease because of triglyceride accumulation. Okay. And acetyl-CoA cannot always enter into fatty acid and cholesterol synthesis. So acetyl-CoA condenses to form ketone bodies. Don't you know acetyl-CoA condenses to form acetoacetate, which is a ketone body. That is why you see ketosis. Pyruvate gets converted to lactate. That is why lactic acidosis. So have you explained all the features here? So tell me, what are the features of von Gierke's disease? Von Gierke's, von is type 1 glycogen storage disorder caused by the defect of glucose 6 phosphatase. It presents with hypoglycemia, hypertriglyceridemia, which is the reason for hepatomegaly, renomegaly, doll-like faces. Hypercholesterolemia, which is the reason for xanthomas, ketosis and lactic acidosis. Okay. Y for what? Medico, what is your Y for? Pyruvate converted to lactic acid. Yes. Pyruvate has got multiple fates, Medico. Pyruvate can become acetyl-CoA. or pyruvate can become lactic acid. When glucose 6-phosphate accumulates and becomes pyruvate, some pyruvate will become acetyl-CoA, some pyruvate will become lactic acid. Got it? So, next question. All the following are gluconeogenic enzymes except. What is the right answer? Hi, MedPsycho. All of the following are gluconeogenic enzymes except. Very good, Paras. Very good, Maddie. Yes, the answer is pyruvate dehydrogenase. Because what is the function of pyruvate dehydrogenase? It converts pyruvate to acetyl-CoA. And then this acetyl-CoA enters into citric acid cycle. It does not enter into gluconeogenesis. Okay. PEP-CK is an enzyme of gluconeogenesis, Komal. So let me tell you about gluconeogenesis enzymes. First, tell me what is gluconeogenesis. As I've already told you, gluconeogenesis is reversal of glycolysis. So in glycolysis, you start with glucose, you split it into 2 molecules of pyruvate. In gluconeogenesis, you start with 2 molecules of pyruvate, you end up in 1 molecule of glucose. And to accomplish gluconeogenesis, you should know all the irreversible steps of glycolysis and you should know a means of reversing them. So tell me, what are the irreversible steps of glycolysis? Irreversible steps of glycolysis will include the first step, which is hexokinase or glucokinase. This can be asked as a one-liner. What are the irreversible steps of glycolysis? Hexokinase or glucokinase, phosphofructokinase 1 and pyruvate kinase. In gluconeogenesis, you will have to reverse all these steps. Which step will you reverse first? You will reverse the pyruvate kinase step first. Okay. So what does pyruvate, where do we add phosphate? Please be very specific about your question, Lalit. I don't understand your question. What do you mean by where we add phosphate? So what does pyruvate kinase? If you can elaborate your question, I will be able to help you. Okay. So what does pyruvate kinase do usually? Usually pyruvate kinase catalyzes the last step of glycolysis when it converts phosphoenol pyruvate to pyruvate. So to accomplish gluconeogenesis, you should convert pyruvate to phosphoenol pyruvate. How do you do that? The first enzyme is pyruvate carboxylase. All of you please memorize which is the first enzyme of gluconeogenesis. Pyruvate carboxylase converts pyruvate into oxaloacetate. And the next enzyme is PEP-CK. Yeah, phosphoenol pyruvate carboxykinase converts oxaloacetate to phosphoenol pyruvate. So tell me, what are the 2 steps of gluconeogenesis? The 2 enzymes of gluconeogenesis include number 1 pyruvate carboxylase, number 2 PEP-CK or phosphoenol pyruvate carboxykinase. And then to reverse phosphofructokinase 1 step. Usually phosphofructokinase 1 converts fructose 6-phosphate to fructose 1,6-bisphosphate. So to reverse that, what is the enzyme that you want? You need fructose 1,6-bisphosphatase. Yeah, you need fructose 1,6-bisphosphatase. And then usually hexokinase or glucokinase converts glucose into glucose 6-phosphate. And to reverse this step, you use glucose 6-phosphatase enzyme. So all of you, can you summarize about gluconeogenesis? I am going to tell you all the one-liners that can be asked in gluconeogenesis. All of you answer this along with me. Gluconeogenesis. The first fact that can be asked about gluconeogenesis is, what are the enzymes of gluconeogenesis? What are the 4 enzymes of gluconeogenesis? Pyruvate carboxylase is number 1. PEP-CK, phosphoenol pyruvate carboxykinase, fructose 1,6-bisphosphatase and glucose 6-phosphatase. These are the 4 enzymes of gluconeogenesis. The next question that can be asked is, where are these enzymes present? Pyruvate carboxylase is present in mitochondria, like pyruvate dehydrogenase complex, which converts pyruvate into acetyl-CoA. Pyruvate carboxylase is also present in mitochondria. Whereas the remaining steps of gluconeogenesis happen in cytoplasm. And the last enzyme, glucose 6 phosphatase, is present in endoplasmic reticulum. Do you all understand this? So gluconeogenesis happens in multiple suborganelles. The first step of gluconeogenesis happens in mitochondria. The remaining steps happen in cytoplasm. The last step happens in endoplasmic reticulum. And endoplasmic reticulum is otherwise called as microsome. So if you are asked which is the microsomal enzyme marker, what will be your answer? Microsomal enzyme marker is glucose 6 phosphatase. Okay, so this is a second set of facts that can be asked you. The third set of facts is interesting about the organ in which gluconeogenesis can happen. When all the enzymes of gluconeogenesis are present in all tissues. Okay, all the enzymes of gluconeogenesis are present in all tissues. The only one enzyme which is absent in other tissues but present in liver and kidney, making liver and kidney uniquely gluconeogenic, is glucose 6 phosphatase. So tell me, what are the gluconeogenic organs? Liver and kidney. Okay, that's a third fact that can be asked. The fourth fact is, what are the principal substrates of gluconeogenesis? The principal substrates of gluconeogenesis are number 1 glycerol, number 2 lactate, number 3 alanine. Yeah, glycerol, lactate, alanine are the three principal substrates of gluconeogenesis. The last fact is, how many high energy phosphates will you need to convert 2 pyruvate to 1 glucose? If you start from 2 pyruvate, you need 11 high energy phosphates. Have you understood this? So these are the facts that can be asked in gluconeogenesis. So pyruvate carboxylase, PepCK, fructose 1,6-bisphosphatase, glucose 6 phosphatase are the 4 enzymes of gluconeogenesis. Pyruvate carboxylase is in mitochondria. Remaining enzymes are present in cytoplasm. Glucose 6 phosphatase is present in endoplasmic reticulum. Microsomal enzyme marker is glucose 6 phosphatase. What are the gluconeogenic tissues? Liver and kidney. What are the three principal substrates of gluconeogenesis? Glycerol, lactate and alanine. How many high energy phosphates do you need for gluconeogenesis? 11 high energy phosphates. Okay. If you know this, that's more than enough. Answer this. Just now I gave you the answer. All of the following are gluconeogenic substrates except. I said glycerol, lactate, alanine are the three principal substrates of gluconeogenesis. Which is not a gluconeogenic substrate, it is acetyl-CoA. Very good, Medico. Very good, Aishwarya. I will be happy if all of you give the answer for this question. Answer is acetyl-CoA. Okay. This is an interesting question and I hope all of you would know the answer for this question. A child presents with diarrhea, bloating, flatulence and frothy stools whenever he takes milk. The probable enzyme defect is. What is the right answer? Following intake of milk, you know milk is rich in lactose. After intake of lactose, there is GI symptom. Do you see that all these are gastrointestinal manifestation? Diarrhea, bloating, flatulence and frothy stools. And what is this? This is lactose intolerance. Very good. Good Apurva, good Medico, good Kushbu. Yes. Answer is very good Vignesh, good Komal. The answer is lactase. Okay. So this is lactose intolerance caused by lactase deficiency in the intestinal villi. So before I discuss about lactose intolerance, let me tell you about the other choices. Galactose 1-phosphate uridyl transferase, GalPut. Yeah, galactose 1-phosphate uridyl transferase is shortly called as GalPut. GalPut deficiency causes classical galactosemia. Please memorize it. Classical galactosemia is caused by the defect of galactose 1-phosphate uridyl transferase. Aldolase B is involved in fructose glycolysis and a defect of aldolase B causes hereditary fructose intolerance. It causes hereditary fructose intolerance. So what are the defects that you have learnt about? Lactose intolerance is caused by lactase deficiency. GalPut deficiency causes classical galactosemia. Aldolase B defect causes hereditary fructose intolerance. Now a bit about lactose intolerance. I will be happy. Yes, Komal, you're right. Oil drop cataract. So I'll be happy if you can all start telling me about lactose intolerance. So I told you lactose intolerance is caused by lactase deficiency in the intestinal villi. So lactose in the diet does not get digested. When I say digestion, I mean to say breaking down lactose to give rise to monosaccharides. Even if you don't know this till today, please memorize it. Lactose is a disaccharide made up of galactose and glucose. Disaccharides cannot get absorbed along the intestine. Only after you break down a disaccharide lactose to give rise to two monosaccharides, it can be absorbed along the intestine. So when lactase is deficient in the intestinal villi, lactose is not digested, so it's not absorbed. Because it's not absorbed, it stays back in the intestinal lumen. It is osmotically active, it attracts water. And when it attracts water, that causes osmotic diarrhea. So what will be the predominant manifestation of lactose intolerance? Osmotic diarrhea. Additionally, undigested lactose reaches colon. And we know that a colon is loaded with microorganisms. These microorganisms start utilizing lactose and they convert lactose to form hydrogen and methane. And both hydrogen and methane, no, I have not taken a session on eicosanoids. I'll try to probably discuss about that now. Okay. So lactose gets lactose gets utilized by colonic microorganisms to give rise to hydrogen and methane. And both hydrogen and methane are gases. These gases accumulate in the colon, and that is the reason for bloating, flatulence and frothy stools. So not only in a patient with lactose intolerance, anybody who presents with repeated bloating episodes means there is some digestion defect, there is some absorption defect happening in the intestine, or their colon is loaded with microorganisms. Okay, that is what the inference is. So hydrogen and methane is both hydrogen and methane are gases, and that is responsible for bloating, flatulence and frothy stools. And the hydrogen and methane that accumulate in the colon can also be found in the breath of the patient. And that is why hydrogen breath test and methane breath test can be done to detect lactose intolerance. Sometimes colonic microorganisms convert this lactose into acids. And these acids are responsible for acidic pH of stools. And that is why a neonate with lactose intolerance presents with perianal excoriation. So what is the reason for perianal excoriation? It's because of acidic pH of stools. Okay, so that's all about lactose intolerance, and I want you to understand that lactose intolerance is a digestion defect. So it will not present with metabolic derangements like hypoglycemia or lactic acidosis or hyperuricemia. Lactose intolerance will present only with digestive manifestations or intestinal manifestations like osmotic diarrhea, bloating, flatulence, frothy stools, perianal excoriation. Okay. Answer this. A child presents with hypoglycemia, hypophosphatemia, jaundice and hepatomegaly after transitioning from mother's milk to infant foods. The probable enzyme defect is. Can it be lactase deficiency? No. Lactase deficiency will not present with metabolic derangements like hypoglycemia. It presents only with gastrointestinal manifestations. Can it be galactose 1-phosphate uridyl transferase deficiency? Celiac disease. Why do you say celiac disease here, Bihari? Do you see any gastrointestinal manifestations here? No. Okay, this is not celiac disease. So galput deficiency can also be excluded. Yeah, this is also excluded purely based on history. What does history tell you? After transition from mother's milk, had it been galactosemia caused by galactose metabolism disorder, all these manifestations should have appeared even when the child was mother fed. Because you know mother's milk has got lactose, lactose gets digested to give galactose and glucose. Galactose would have entered into the circulation even then. And a galactose metabolism disorder should have presented even when the child is mother fed. And because the history is after transition to from mother's milk to infant foods, and all formula feeds are rich in sucrose. So like what I told you about lactose, sucrose is also a disaccharide. Your table sugar sucrose is also a disaccharide, which is made up of glucose and fructose. So after intake of infant feeds, sucrose would have got digested to give glucose and fructose. Fructose has started entering into the system. After that, you see all these manifestations. So it is hereditary fructose intolerance caused by the defect of what? Aldolase B. Clear? So answer here is aldolase B. A 22-year-old male presents with hemolytic anemia following intake of primaquine. I already gave you the answer for this question. The probable enzyme defect is. So whenever there is a case-based MCQ, as I've already told you, you need to follow 2 steps. Step number 1 is to summarize positive findings. Step number 2 is to start excluding choices. Okay. So summarizing the positive finding here, hemolytic anemia following exposure to an oxidative stress. Best source of reducing equivalent NADPH for fatty acid synthase complex in liver. How to choose between HMP shunt, glycolysis, malate, oxaloacetate. Okay. So Komal Chandra has got a question about sources of NADPH. You don't have to worry about glycolysis at all in this case, because glycolysis is never a source of NADPH. So what are the sources of NADPH? Can you all tell me the differences between NADPH and NADH? This is often asked in FMGE. So what are the differences between NADPH and NADH? NADPH enters into, NADH enters into electron transport chain, and NADH can give rise to 2.5 ATPs. Whereas NADPH cannot enter into electron transport chain, it can never give rise to ATP. That's the first difference. What is the second difference? What is the use of NADPH? NADPH is necessary for reductive biosynthesis of all the lipids, be it fatty acid synthesis or cholesterol synthesis or bile acid synthesis or steroid hormone synthesis. All these lipid synthetic pathways will need NADPH. Okay, so that's the first use of NADPH. The second, very good all of you, good Maze. Yes. So that is the first use of NADPH. The second use of NADPH is it is necessary for regenerating glutathione. NADPH is necessary for regenerating glutathione, which is an important antioxidant mechanism of RBCs. The third use of NADPH for ribonucleotide reductase. The last use of NADPH, it is necessary for cytochrome P450 enzymes. This was asked in the Jan FMGE exam. Cytochrome P450 uses what? Your answer should be NADPH. Okay. So uses of NADPH will include lipid synthesis, regenerating glutathione, which is an important antioxidant mechanism for RBCs, ribonucleotide reductase, and cytochrome P450 enzymes. Okay. Now the last difference between NADH and NADPH will be sources. Tell me, what are the sources of NADH? Sources of NADH will include all catabolic steps. For example, glycolysis, right? Glycolysis, citric acid cycle, fatty acid oxidation. So all these pathways can act as a source of NADH. Whereas what are the sources of NADPH? Yeah. There are 3 sources of NADPH. The first source of NADPH is HMP shunt. The major source of NADPH is HMP shunt. Second source is cytoplasmic isocitrate dehydrogenase. The third source of NADPH is malic enzyme, which converts malate to pyruvate. Yeah, please memorize it. The 3 sources of NADPH will be HMP shunt, cytoplasmic isocitrate dehydrogenase, and malic enzyme, which converts malate to pyruvate. Now do you know the answer, Komal? Yeah, The major source of NADPH for fatty acid synthesis or cholesterol synthesis or bile acid synthesis would be HMP shunt. Okay. So the history, what was the history? The history was hemolytic anemia following exposure to oxidative stress. So whenever there is a case-based MCQ asking you to solve a case of hemolytic anemia, you should differentiate between the two major causes. The first common cause would be G6PD deficiency, and then it is glycolytic defect. Yeah, metabolic cause of hemolytic anemia can be either G6PD deficiency or glycolytic enzyme defect. Why? Because when there is G6PD deficiency, what is not synthesized? NADPH is not synthesized. What is not regenerated? Glutathione is not regenerated. So there is no antioxidant mechanism in RBCs. So RBCs become susceptible to lysis following exposure to oxidative stress. So the history for G6PD deficiency will be very classical. Yeah, a child will be developing normally until the child gets exposed to a source of oxidative stress. For example, after intake of primaquine. What is primaquine? A prophylactic drug for malaria. Or after exposure to fava beans. So if you see such a history, then it is G6PD deficiency. Now, why should glycolytic enzyme defect present with hemolytic anemia? It is because RBCs are completely dependent on glycolysis for ATP production. So whenever there is a glycolytic enzyme defect, RBCs get affected. That will present as hemolytic anemia. Not only RBCs, even white muscle fibers get affected whenever there is a glycolytic enzyme defect. And when white muscle fibers get affected, that will present as exercise intolerance. Okay, so if the history says there is a person who is presenting with hemolytic anemia, for example, they say the bilirubin level is elevated, indirect bilirubin level is high, and then there is additionally there is LDH, lactate dehydrogenase level, which is elevated, reticulocytosis is observed. So all these will point towards the presence of hemolytic anemia. Additionally, they have also mentioned that the child also presents with exercise intolerance. If you see this combination, always think of a glycolytic enzyme defect. Is that clear to all of you? Very good, Biomaze, you're right. Excellent. So, what is the right answer? Following intake of primaquine, what is a probable enzyme defect? The probable enzyme defect is G6PD, glucose 6-phosphate dehydrogenase. Okay. And this is again a frequently asked topic. Insulin dependent glucose uptake happens in all except. Yeah, insulin dependent glucose uptake happens in all except. Very good, Komal. The answer is endothelium. Okay, so the first fact that you should all remember about insulin dependent glucose uptake is it is through GLUT4 transporters. Bihari says A, Medico says D, Komal says A. No. So skeletal muscle, cardiac muscle, adipose tissue, all these are dependent on insulin. Okay, so let me tell you about insulin dependent glucose uptake. All of you watch this. Insulin dependent glucose uptake happens through GLUT4 transporters, and these GLUT4 transporters get upregulated in the membranes of skeletal muscle, cardiac muscle and adipose tissue. If you're asking me how to memorize this list, I want you to remember that insulin is an anabolic hormone. So insulin will stimulate glucose uptake only into those tissues wherein glucose can be used for anabolism. And insulin is very sure that if it stimulates glucose uptake into skeletal muscle and cardiac muscle, here glucose will be stored as glycogen, which is anabolism. If it stimulates glucose uptake into adipose tissue, the glucose will be converted to fat and it gets stored. That is also anabolism. Are you clear about this? So you should all have this in your memory. Okay, so insulin dependent glucose uptake happens through GLUT4 transporters which get upregulated on the membranes of skeletal muscle, cardiac muscle and adipose tissue. Now, how about liver? Anabolic, catabolic. Yes, anabolic is insulin. Is your doubt? What's your doubt, Komal? Insulin is an anabolic hormone. All the other counter-regulatory hormones of insulin are catabolic. Okay. So, though GLUT4 transporters get upregulated only in these tissues, insulin-dependent glucose uptake also happens in liver. How does it happen in liver? Because liver has got an enzyme glucokinase. And this glucokinase is stimulated by insulin. So, as long as there is insulin in a body, insulin stimulates glucokinase. This glucokinase stimulates the conversion of glucose into glucose 6-phosphate within the liver. This causes glucose level within the liver to be low and that causes glucose uptake to happen into the liver. Are you all clear about this? Yeah. So tell me the answer for this question. Insulin dependent glucose uptake happens in all except. Yes, it happens in skeletal muscle, in cardiac muscle, adipose tissue, as well as in liver. Where do you think it does not happen? It does not happen in endothelium. Okay. So why should you know this? Can anybody tell me what is the reason behind you being expected to know this? Why should you know that insulin dependent glucose uptake happens in skeletal muscle, cardiac muscle, adipose tissue and in liver? Only when you understand this, you will understand the manifestations of diabetes. All of you tell me what is diabetes? Diabetes is absolute or relative insulin deficiency. And whenever there is absolute or relative insulin deficiency, all those tissues which are dependent on insulin for glucose uptake will not be able to take up glucose. So what are the tissues which cannot take up glucose? Skeletal muscle, cardiac muscle, adipose tissue, liver. All these cells cannot take up glucose and that causes hyperglycemia. If glucose cannot get into these tissues, where will glucose stay? It stays back in the circulation. When there is hyperglycemia, excess glucose will enter into those tissues which are independent of insulin for glucose uptake. And in those tissues, it causes glucose toxicity. For example, lens glucose uptake is independent of insulin. So in diabetes, when there is excess glucose, glucose enters into lens. And as long as glucose is in the form of glucose within the lens, it does not cause any derangement. But lens has got an enzyme by name aldose reductase. And this aldose reductase acts on glucose and converts it into sorbitol. Yeah, aldose reductase acts on glucose and converts it into sorbitol. Once it becomes sorbitol, it gets trapped within the lens. And this sorbitol attracts water that causes swelling of lens fibers that begins cataract as changes. So tell me which enzyme is responsible for diabetic cataract? The enzyme that is responsible for diabetic cataract is aldose reductase. Tell me which alcohol is responsible for diabetic cataract? It is sorbitol. Okay. And similarly, endothelial glucose uptake. Yeah, endothelial glucose uptake is independent of insulin. So excess glucose enters into endothelium. There, glucose toxicity is the reason for microvascular and macrovascular complications of diabetes. Atherosclerosis is a macrovascular complication of diabetes that is caused predominantly by glucose toxicity happening in endothelium. Neuronal glucose uptake is independent of insulin. There it causes neuropathy. Renal glucose uptake is independent. That causes nephropathy. Do you understand all these? Yeah. So that is about why you should know what are the tissues which are dependent on insulin, what are the tissues which are independent of insulin for glucose uptake. Now let's learn about all the GLUT transporters. It's not enough. If you just know about GLUT4 transporters, you might be asked about other GLUT transporters as well, right? So first tell me about what you already know. GLUT4 transporters, where are they present? GLUT4 is present in skeletal muscle, cardiac muscle, adipose tissue. Now about GLUT1 and GLUT3. My pleasure, Aishwarya. So GLUT1 and GLUT3, these are the transporters which are present in those cells for which glucose is indispensable. Tell me, what are the cells for which glucose is indispensable? Just now I told you RBCs, right? RBCs, neurons. Neurons also use glucose, right? RBCs, neurons and placenta. So in RBCs, neurons and placenta, we have GLUT1 and GLUT3 transporters. GLUT2 transporters are present in those cells which are related to glucose balance. What are the cells which are related to glucose balance? Glucose has to be absorbed by enterocytes. Glucose has to be stored by hepatocytes. And pancreatic beta cells should be releasing insulin. And PCT should reabsorb glucose, right? Proximal convoluted tubule should be able to reabsorb glucose. And in all these places, you have GLUT2 transporters. So GLUT2 transporters are present in enterocytes, hepatocytes, pancreatic beta cells, and renal tubular cells. GLUT5 is related to fructose absorption. Okay, GLUT5 is related to fructose absorption. It's present in enterocytes. Okay, so that's all about GLUT transporters. So what is the right answer here? The right answer here is endothelium. Most essential fatty acid is. This is again a frequently asked MCQ. Most essential fatty acids are linoleic acid and alpha linolenic acid. Okay, linoleic acid and alpha linolenic acid are the two nutritionally essential fatty acids. I want you to remember that both these fatty acids have 18 carbon atoms. Linoleic acid is of omega 6 type. Alpha linolenic acid is of omega 3 type. Please memorize it. Linoleic, the name is smaller, the number is bigger. Linoleic is 18 carbon atom, omega 6 type. Alpha linolenic, 18 carbon atom of omega 3 type. Okay. And if they ask you, is arachidonic acid nutritionally essential? What will be your answer? No, arachidonic acid is not nutritionally essential. It's a semi-essential fatty acid. Answer this. These are one-liners that can be asked to you. Surfactant is a what? Yeah, I will tell you. Yeah, surfactant is a lecithin. So surfactant, the major chemical composition of surfactant is dipalmitoyl phosphatidyl And what is phosphatidyl It is lecithin. Okay, so surfactant is a lecithin. Let us fill up this tabular column to know the chemical names and common names which can be asked as MCQs. The first one, just now I told you, phosphatidyl is nothing but what? Phosphatidyl is nothing but lecithin. The next one is phosphatidyl ethanolamine. Okay, phosphatidyl ethanolamine is cephalin. Diphosphatidylglycerol. glycerol. The third one is diphosphatidylglycerol, glycerol, which is nothing but cardiolipin. Okay, so these are the which amino acid causes amino aciduria. I will tell you about cystinuria, Komal. So I will tell you about eicosanoids and cystinuria now. First about phosphatidyl is lecithin, phosphatidyl ethanolamine is cephalin, diphosphatidylglycerol is cardiolipin. Okay. So let me tell you about eicosanoids. So eicosa means 20. Okay, eicosa means 20. So eicosanoids are physiologically important substances that can be synthesized from a 20 carbon atom containing fatty acid like arachidonic acid. So if arachidonic acid enters into, if arachidonic acid has decided to enter into eicosanoid synthesis, the first enzyme to act on it will be cyclooxygenase. Okay, what is it? Yeah. So we have cyclooxygenase pathway and lipoxygenase pathway. When cyclooxygenase acts on arachidonic acid, what you get is prostaglandin G2. Okay. So when prostaglandin G2 is formed, from there you can form prostaglandin H2. Okay, so I also want you to know that this prostaglandin G2 can also be converted to thromboxane A2 or prostacyclin. Okay, so many a times students get confused because why should one pathway give rise to two different compounds of contrast activities, right? Because what is the function of prostacyclin? Prostacyclin causes vasodilatation. Yeah, prostacyclin causes vasodilatation. It inhibits platelet aggregation. Whereas thromboxane A2 causes vasoconstriction and it causes platelet aggregation. So why should cyclooxygenase pathway give rise to two compounds of exactly contrast features? It is because whether prostacyclin is formed or thromboxane A2 is formed depends upon whether cyclooxygenase pathway is happening in endothelium or in platelets. When cyclooxygenase pathway happens in endothelium, endothelium has got only prostacyclin synthase. So that will form only prostacyclin that causes vasodilatation and inhibition of platelet aggregation. When the same cyclooxygenase pathway happens in platelets, platelets have only thromboxane A2 synthase that helps in platelet aggregation. And this is why aspirin can act as an antiplatelet drug. You know, aspirin is acetyl salicylic acid, which acetylates and irreversibly inhibits cyclooxygenase. When you irreversibly inhibit cyclooxygenase, logically there should be an inhibition of both thromboxane A2 synthesis and prostacyclin synthesis. But how does it act as an antiplatelet drug? It is because endothelial cells are rapidly dividing labile cells that get replenished at the earliest. So even if aspirin goes and inhibits cyclooxygenase in one endothelial cell, that cell gets replenished quickly. So the new cell will have active cyclooxygenase. Whereas platelets, mature platelets do not have protein synthesizing machinery. So in them, an enzyme once inhibited is inhibited forever. So which inhibition is predominant here? Thromboxane A2 inhibition. Thromboxane A2 synthase inhibition is predominant here. And that is why it acts as an antiplatelet drug. Do you all understand this? Yeah, so that's about cyclooxygenase pathway. So cyclooxygenase pathway gives rise to prostaglandin G2, H2, D2, E2. But what is important is prostacyclin, thromboxane A2. Okay. And then the same time, arachidonic acid can also be acted upon by lipoxygenase. So when it is acted upon by lipoxygenase, first you get, one second. So when lipoxygenase acts on arachidonic acid, it starts giving rise to leukotrienes. Okay, so we have 5 lipoxygenase pathway, 12 lipoxygenase pathway, but which is more important? 5 lipoxygenase is more important because that is the enzyme which gives rise to leukotrienes. The first leukotriene that you get is leukotriene A4. Okay, and then it becomes leukotriene C4. We get leukotriene D4 and leukotriene E4. And what is the function of all these leukotrienes? You know, these are the chemical mediators of all the manifestations of bronchial asthma, right? That is why 5 lipoxygenase inhibitor Zileuton, right? 5 lipoxygenase inhibitor Zileuton can be used to avoid asthmatic attacks. Because leukotriene A4, B4, C4, D4, E4, all these will cause bronchoconstriction and increase in mucus production. Okay, so this is an overall view about eicosanoid synthesis. Yeah, it's a Zileuton acts, it won't act as a bronchodilator. It can prevent bronchoconstriction because it prevents the synthesis of leukotriene A4, C4, D4 and E4. Okay. The other question was about cystinuria. There is an MCQ on cystinuria. When we discuss that, I will tell you about it. Okay. So try to answer this. A 38-year-old male presents with yellowish discoloration of palmar creases. Do you see that here? Yeah, do you see that in the image? Yellowish discoloration of palmar creases, which we call as xanthoma palmaris striae. Okay, this is called as Xanthoma palmaris striae, and that is a pathognomonic feature of type 3 hyperlipoproteinemia. Okay, type 3 hyperlipoproteinemia is caused by the defect of ApoE. 3 and E sound similar, right? 3 and E sound similar. So type 3 hyperlipoproteinemia is caused by the defect of ApoE. And in this condition, you see a broad beta band on lipoprotein electrophoresis. That is why this disorder is also called as broad beta disease or familial dysbeta lipoproteinemia. So there are few names for type 3. What is type 3? Type 3 is otherwise called as broad beta disease or familial dysbeta lipoproteinemia. This is a favorite topic of all competitive and clearance exams because there are few pathognomonic features of this condition. This can be asked as an image based question. If you are shown an image wherein there is an yellowish discoloration of palmar creases, then what should come into your mind? It should be type 3 hyperlipoproteinemia wherein there is a defect of ApoE, and it is called as a broad beta disease because there is a broad beta band on lipoprotein electrophoresis. Okay, so read this question. A 38-year-old male presents with yellowish discoloration of palmar creases. His cholesterol is 300 milligram per deciliter. What is a normal serum cholesterol, all of you? Normal serum cholesterol is less than 200 milligram per deciliter. So here cholesterol level is elevated. Triglyceride normal value is 150 milligram per deciliter. That is also elevated. So this is a mixed dyslipidemia. There is an elevation of both cholesterol and triglyceride. And what is expected in this lipoprotein electrophoresis? What did I tell you is expected in lipoprotein electrophoresis? A broad beta band. Okay. Now for all of you, for those of you who are watching this session, I am going to give you an overview of Fredrickson's classification of hyperlipoproteinemias, an overview of how to answer an MCQ based on this topic. Okay, there are 6 types of hyperlipoproteinemias. Good evening, Ashok. No, Shlok. Good evening, Shlok. So there are 6 types of hyperlipoproteinemias. Type 1, 2A, 2B, 3, 4 and 5. Okay, and if you start learning about them individually, you will get confused. So let's group these 6 types of hyperlipoproteinemias into 3 categories. Okay, so the first category presents with only an elevation of cholesterol. The second category presents with only an elevation of triglyceride. The third category presents with an elevation of both. Okay, why should you classify these disorders this way? Because clinical manifestations and management will differ based on this. If there is only an elevation of cholesterol, then the person presents with tendon xanthomas. If there is only an elevation of cholesterol, the person presents with tendon xanthoma and accelerated atherosclerosis. If you're asking me what are tendon xanthomas, these are small eruptive lesions which are present along the line of attachment of tendons. For example, they are found along the ankles. Can you see that here? Yeah, they are found along the ankle or along the knuckles. So these are tendon xanthomas. If you see tendon xanthomas, what should you suspect? An elevation of cholesterol. Whereas if it's an elevation of only triglyceride, then they present with eruptive xanthomas. So tendon xanthomas are totally different from eruptive xanthomas. Recurrent pancreatitis, and on examination you will find lipemia retinalis. So tell me, what are the features of hypertriglyceridemia? Eruptive xanthomas, recurrent pancreatitis, and on examination you will find lipemia retinalis. So I have personally seen a patient, actually a 4-month-old infant, yeah, a 4-month-old infant was identified with lipemia retinalis. Ophthalmoscopic examination just revealed lipemia retinalis. Actually, the infant got admitted just with bleeding rectum. Okay, so as an overall examination, they did an ophthalmoscopic examination, they found lipemia retinalis, and then we got a blood sample, and the blood sample was milky. The plasma was literally milky, like milk. Okay, and triglyceride levels were so high that we could not even estimate it. And that happened to be a case of an isolated hypertriglyceridemia. Okay, So these are eruptive xanthomas. This is how they look. These are even tinier than tendon xanthomas, and they are present along the extensor surfaces of limbs. For example, along the elbows. Okay. So this is about eruptive xanthomas. And if it's a combination of both, you will find a combination of both these features. You will see both tendon xanthomas and eruptive xanthomas. There will be accelerated atherosclerosis. There can be a history of recurrent pancreatitis. Now, what are the hyperlipoproteinemias which present with only an elevation of cholesterol? Only an elevation of cholesterol is seen in type 2A, as some of you had answered it already. Comal DD phrenoderma. This is not phrenoderma. In phrenoderma, what you would see is a keratin plug in the tip. Small eruptive lesions. If you see a keratin plug in the tip, then that is phrenoderma. What is phrenoderma? It is follicular hyperkeratosis. Yeah, follicular hyperkeratosis will present with a keratin plug in the tip. And this phrenoderma is caused by vitamin A deficiency or essential fatty acid deficiency. In eruptive xanthomas, you don't see a keratin plug. Okay. So the only condition which presents with an elevation of cholesterol is type 2A. That is why type 2A is otherwise called as familial hypercholesterolemia. And this is caused by a defect of LDL receptor. Just think logically what is expected when LDL receptor is defective. LDL will not be cleared off from the circulation. And LDL carries cholesterol. When LDL accumulates in the circulation, cholesterol level will be elevated. And this is an autosomal dominant condition. So all of you please repeat this along with me. Yes. Repeat this along with me. In which condition will you see only an elevation of cholesterol type 2A? That is why it's called as familial hypercholesterolemia caused by a defect of LDL receptor. It's an autosomal dominant condition. Now, what are the disorders which present with an elevation of only triglyceride? Only triglycerides are elevated in type 1, type 4 and type 5. Yeah, 1 plus 3 is 4, right? Triglyceride is 3. So type 1, type 4 and type 5, these are hypertriglyceridemias. Elevation of both will be seen in remaining conditions. What are the conditions which are left out? Type 2B and 3. Okay, in type 2B and 3, you find an elevation of both. So didn't you observe that in the question? Xanthoma palmaris striae with an elevation of both cholesterol and triglyceride points towards a diagnosis of type 3, which is dys-beta lipoproteinemia with a broad beta band. Okay, so what are the facts that you need to know about type 3 hyperlipoproteinemia? I said 3 and E sound similar. So type 3 is caused by a defect of ApoE. Okay, and ApoE is an apoprotein of remnant lipoproteins. So when there is an ApoE defect, remnant lipoproteins do not get cleared off from the circulation. Remnants accumulate. That is why this condition is called as remnant disease. Remnants carry both cholesterol and triglyceride. That is why in type 3 hyperlipoproteinemia, both cholesterol and triglycerides are elevated. Okay, and this is otherwise called as familial dys-beta. How to learn the receptor defect? I don't understand your question. This is otherwise called as broad beta disease because on lipoprotein electrophoresis you see a broad beta band, and it's also called as familial dys-beta lipoproteinemia. Okay, and I told you it is caused by E defect. To be very specific, it is caused by homozygous E2 allele. All of us, yeah, if we have a normal lipid profile, which means we have homozygous E3. If there is a mutation and if E3 is replaced by E2, that causes familial dys-beta lipoproteinemia. Dermatological findings are 2. So tell me, what are the two findings that you can see dermatologically? One is palmar eruptive xanthomas. Do you see that here? Eruptive xanthomas, if they are seen on the palm. Palmar eruptive xanthomas, pathognomonic of type 3 hyperlipoproteinemia. Similarly, xanthoma palmaris striae. Okay. What is the right answer? The right answer here is broad beta band. Answer please. The rate limiting enzyme of fatty acid synthesis is fatty acid synthesis. Tell me, what is a precursor for fatty acid? How to remember, how to learn receptor defects only by repetition, Komal. Okay, just keep repeating it. So far I've told you about 2 receptor defects. LDL receptor defect, what did I tell you? That is type 2A. ApoE defect, that is type 3. Acetyl-CoA carboxylase is the rate limiting enzyme of fatty acid synthesis. And how to remember this? The precursor of fatty acid is acetyl-CoA. So the enzyme has to be acetyl-CoA carboxylase. So can we learn about all rate limiting enzymes of lipid synthetic pathway? Yeah. So let's start with fatty acid synthesis. Just now I told you the precursor of fatty acid is acetyl-CoA. So the rate limiting enzyme is acetyl-CoA carboxylase. What is the rate limiting enzyme of fatty acid oxidation? Where do fatty acids get oxidized? Most of the fatty acids get oxidized in mitochondria. But as fatty acids, they cannot cross the inner mitochondrial membrane. They need a carrier. What is the carrier? This was asked recently in NEET PG. The carrier which carries fatty acid across the inner mitochondrial membrane is carnitine. So now tell me, what is the rate limiting enzyme of fatty acid oxidation? It has to be carnitine acyl transferase 1. Yeah, for fatty acid oxidation, the rate limiting enzyme is carnitine acyl transferase 1. I will tell you about HMG Bihari. Please wait for some time. So fatty acid synthesis, fatty acid oxidation. Now about cholesterol synthesis. Can you tell me statins act by inhibiting which enzyme? Statins act by inhibiting HMG-CoA reductase. Thereby they reduce the blood cholesterol level, which means what is the rate limiting enzyme of cholesterol synthesis? It is HMG-CoA reductase. What is the rate limiting enzyme of ketone body synthesis? The initial few steps of cholesterol synthesis and ketone body synthesis are the same. Until you form HMG-CoA, both the pathways are identical. After HMG-CoA is formed, then HMG-CoA lyase or HMG-CoA synthase acts on HMG-CoA. You get the first ketone body, which is acetoacetate. So which is the rate limiting enzyme of ketone body synthesis? It is HMG-CoA lyase or HMG-CoA synthase. What is the rate limiting enzyme of bile acid synthesis? Do you all know that bile acids are hydroxylated forms of cholesterol? Even if you don't know that, I hope you all remember that bile acids are derivatives of cholesterol and you get these bile acids by hydroxylation. So the rate limiting enzyme is 7-alpha hydroxylase. So are you clear about this? Yeah, so can you repeat this along with me? Are you clear about this, Bihari? Yeah, fatty acid synthesis. What is the rate limiting enzyme? It is acetyl-CoA carboxylase. For fatty acid oxidation, remember it is carnitine, which is the carrier. So the rate limiting enzyme is carnitine acyl transferase 1. For cholesterol synthesis, it is HMG-CoA reductase. For ketone body synthesis, HMG-CoA synthase. For bile acid synthesis, it is 7-alpha hydroxylase. So what is the right answer? The rate limiting enzyme of fatty acid synthesis is acetyl-CoA carboxylase. Ketone bodies are synthesized in where? Answer please. Ketone bodies are synthesized in liver. Yeah. So there are 2 facts that I want you all to remember. The first fact is ketone bodies are synthesized in liver, but ketone bodies cannot be utilized by liver. Ketone bodies are used by extrahepatic tissues, predominantly by brain. Do you understand this? Ketone bodies are synthesized in liver, but they are utilized by extrahepatic tissues. They are utilized by brain predominantly. And if you ask, why can't liver utilize ketone bodies? Because liver lacks an enzyme, thiophorase. Please don't get confused here. It is not thiolase. It is not thioesterase. Which enzyme is absent in liver, because of which liver cannot utilize ketone body? It is thiophorase. Okay. Good, Surya. Stearic acid on complete oxidation provides how many ATPs? I will give you a clue. Stearic acid has got how many carbon atoms? 18 carbon atoms. How many ATPs do you get from stearic acid on complete oxidation? Very good, Surya. It is 120 ATPs. Bihari, 106 ATPs what you get from palmitic acid. Yeah, palmitic acid with 16 carbon atoms on complete oxidation will give you 106 ATPs. Stearic acid with 18 carbon atoms on complete oxidation will give you 120 ATPs. So already did we discuss about number of ATPs? Can you all recollect and tell me those numbers? Aerobic glycolysis, how many ATPs? There is no secret or shortcut to memory. Do you all know that? There is no secret or shortcut to memory. The only way you can memorize all facts and concepts is repetition. So please don't feel tired of repeating anything. More the number of times you repeat a topic, more the number of times you try revising a topic, better will be your memory. Okay, so that's not a waste of time. Yeah, many a time students get confused between wasting time and optimally utilizing time. Yeah, repetition is not a waste of time. The more the number of times you repeat, better will be your memory. So tell me, aerobic glycolysis, how many ATPs? 7 ATPs. Anaerobic glycolysis, how many ATPs? 2. Complete oxidation of one molecule of glucose gives you 32 ATPs. Citric acid cycle gives you how many ATPs? 10 ATPs. Glycogen synthesis, for you to add 1 mole of glucose, you will have to invest 3 high energy phosphates. Okay. Gluconeogenesis, how many high energy phosphates? 11 high energy phosphates. Now about lipid pathways. Yeah, energetics related to lipid pathways. There are 3 numbers that I want you to memorize. The first one is palmitic acid. Should never get confused here. Palmitic acid with 16 carbon atoms will give you how many ATPs? 106 ATPs. Stearic acid on complete oxidation gives you 120 ATPs. And the third one, this is not related to lipid, it is related to protein. For protein synthesis, yeah, for protein synthesis, for you to attach every amino acid, you will have to invest 4 high energy phosphates. Yeah, for protein synthesis, for you to attach every amino acid to a growing polypeptide chain, you have to invest 4 high energy phosphates. Okay. Yes, try to answer this please. Primary bile acid is what? Is it bilirubin, biliverdin, cholic acid, lithocholic acid? What is the right answer? Bilirubin, biliverdin can be excluded. Yes or no? Because both are bile pigments. You know that, right? Bile pigments or catabolic products of heme. Whereas bile acids are derivatives of cholesterol. Primary bile acid is cholic acid. Okay, primary bile acid is cholic acid. So I'm going to tell you about bile acids now. Listen to this carefully because they often ask you about what are the primary bile acids, what are the secondary bile acids, what are the bile salts. You should not get confused here. Okay, so derivatives of cholesterol are bile acids. When cholesterol is acted upon by 7-alpha hydroxylase, okay, when it's acted upon by 7-alpha hydroxylase, you get 2 bile acids. One is cholic acid, the other one is quinodeoxycholic acid. Have you memorized it? One is cholic acid, the other one is quinodeoxycholic acid. And these cholic acid and quinodeoxycholic acid undergo conjugation with glycine and taurine. This was once asked in FMGE. Major conjugation happens with glycine, not with taurine. Okay, and glycine and taurine conjugated cholic acid and chenodeoxycholic acid are primary bile acids. And when you drop these bile acids in alkaline bile, they form salts. Those are called as bile salts. These bile components enter into the intestine. In the intestine, colonic microorganisms first deconjugate primary bile acids and they dehydroxylate them at the 7th position. Such deconjugated, dehydroxylated primary bile acids will become secondary bile acids. So what are the secondary bile acids? From cholic acid, you get deoxycholic acid. From chenodeoxycholic acid, you get lithocholic acid. And this is done by the action of intestinal microorganisms. Do you all understand this? Yeah, so that's about primary bile acids and secondary bile acids. So what are the primary bile acids? Glycine and taurine conjugated. Cholic acid and chenodeoxycholic acid are primary bile acids. These bile acids undergo deconjugation and dehydroxylation done by colonic microorganisms to form secondary bile acids. What are the secondary bile acids? Deoxycholic acid and lithocholic acid. And there is one other one-liner that can be asked to you. Out of these bile components which do not undergo enterohepatic circulation, only lithocholic acid cannot undergo enterohepatic circulation. Okay. Which of the following is an activator of lipoprotein lipase? What is the right answer? Which of the following is an activator of lipoprotein lipase? It is ApoC2. Okay, answer is ApoC2. ApoA1 is an activator of LCAT. Okay, ApoA1 is an activator of LCAT. So now I am going to tell you about functions of apoproteins and lipoproteins. Okay, this is often asked as one-liners. So apoproteins of lipoproteins perform one or the other function. One function is they act as regulators. All these apoproteins act as regulators for enzymes which are concerned with their metabolism, or they act as ligands. Yeah, they act as ligands for the receptors which are concerned with their metabolism. Example for apoproteins acting as regulators for enzymes will be ApoC2 activates lipoprotein lipase. ApoC3 inhibits lipoprotein lipase. ApoA1 activates LCAT. What is LCAT? LCAT is lecithin cholesterol acyltransferase. Okay, so ApoA1 activates lecithin cholesterol acyltransferase. Example for apoproteins acting as ligands for receptors will be ApoE. ApoE is accepted by remnant receptors. Didn't I tell you? ApoE is an apoprotein of remnant lipoproteins. So ApoE is accepted by remnant receptors. ApoB100 is accepted by LDL receptors. So are you clear about functions of these apoproteins? Now tell me the answer for this question. Which of the following is an activator of lipoprotein lipase? It is ApoC2. ApoC3 inhibits lipoprotein lipase. ApoA1 activates LCAT. Okay. You should be able to answer this. A 32-year-old male, because we have already learned about Fredrickson's hyperlipoproteinemias. A 32-year-old male presents with an acute attack of myocardial infarction. His cholesterol is 450 milligram per deciliter. Very good, Komal. Cholesterol is 450, which is elevated. Triglyceride is almost normal, right? So there is an isolated elevation of cholesterol. The person presents with tendon xanthomas and accelerated atherosclerosis. So isolated elevation of cholesterol is type 2A. That is why type 2A is otherwise called as familial hypercholesterolemia. Okay. So now do you see that you're able to answer case-based MCQ if you have a conceptual understanding of biochemistry? Yeah. So do not accept if anybody tells you that biochemistry is a preclinical subject. It is not a preclinical subject. It's a subject which has got clinical relevance be it any disorder, yeah, you will not be able to understand, you will not be able to manage any patient if you don't have a conceptual understanding of biochemistry. Okay. So answer this. The optically inactive amino acid is, yes, you have to integrate it with all the other subjects. The optically inactive amino acid is glycine. Okay, so there are few facts that you need to know. Very good, Surya. Very good, Bihari. There are few facts that can be asked as one-liners for glycine. The first fact is glycine is the simplest amino acid. Why am I calling it as the simplest amino acid? Because in glycine, the R group is just a H. Okay, and this glycine does not have any asymmetric carbon atom. And only those structures which have an asymmetric carbon atom will be able to exhibit stereoisomerism. So if they ask you which amino acid does not exhibit stereoisomerism, your answer should be glycine. Only those structures which exhibit stereoisomerism can be optically active. So which amino acid is optically inactive? It is glycine. Okay. And the last fact about glycine is glycine disrupts alpha helix. There are two amino acids which disrupt alpha helix, which is being frequently asked. One is proline, the other one is glycine. Okay, proline and glycine disrupt alpha helix. So have a look at this slide and read it out. This will help you in having a picture memory. It's the simplest amino acid. It has no asymmetric carbon atom. It cannot exhibit stereoisomerism. It is optically inactive. It disrupts alpha helix. Okay. So that's about glycine. Let me tell you few facts about other choices which are provided here. Tryptophan. What is a fact that you need to know about tryptophan? It is one of the 3 aromatic amino acids. What are the 3 aromatic amino acids? Phenylalanine, tyrosine, tryptophan. Okay, and all these 3 aromatic amino acids absorb UV light at 280 nanometer. All aromatic amino acids absorb UV light at 280 nanometer. And for tryptophan, there is a mnemonic. Please memorize it. The mnemonic is TIA. So what does TIA stand for? Tryptophan has got an indole ring. Yeah, tryptophan has got an indole ring and it answers aldehyde test. Tryptophan has got an indole ring and it answers aldehyde test. Yes, you can get it, Aman. I will share it in the Telegram group. Okay. The amino acid which acts as a physiological buffer. Tell me which amino acid acts as a physiological buffer. It is histidine. pK of histidine. pK of histidine is 6. pK of histidine is 6, which is close to the physiological pH of 7.4. So histidine acts as a physiological buffer. So there is a mnemonic for histidine as well. It is HIP. What does HIP stand for? H stands for histidine, I stands for imidazole group, and P stands for Pauli's test. So histidine has got an imidazole ring and it answers Pauli's test. What is the other mnemonic I gave you? TIA. What does TIA stand for? Tryptophan has got an indole ring and it answers aldehyde test. Okay. Which of the following amino acids disrupts alpha helix? Tell me what are the 2 amino acids I told you will disrupt alpha helix. One is proline, the other one is glycine. And if you are given both among choices, go for proline because that's a major disruptor of alpha helix. Okay. Proline is a better answer. Collagen, okay. So I will tell you about collagen. So collagen, the first fact that you need to know about collagen is that it is a triple helix. Why am I calling it as a triple helix? Because it has got 3 polypeptide chains which are organized in a helical fashion. And each and every one of these polypeptide chains have around 1000 amino acids. And these 1000 amino acids are arranged as repetitive units of glycine XY. Okay, these 1000 amino acids of individual polypeptide chains in the triple helix are made up of repetitive units of glycine XY. So this has been asked previously. The major amino acid of collagen is glycine. Okay, and here X and Y can be proline and hydroxyproline. And as far as collagen synthesis is concerned, it is synthesized by ribosome, which is attached to endoplasmic reticulum. So when it is first getting synthesized, it will be a simple alpha collagen. Yeah, it is called as an alpha collagen. And this alpha collagen will have proline and lysine. But what needs to be done is, you will have to hydroxylate these proline and lysine residues. That is done by prolyl hydroxylase and lysyl hydroxylase. And prolyl hydroxylase and lysyl hydroxylase, both these are dependent on vitamin C. And that is why we say that vitamin C is necessary for collagen maturation. Because only after hydroxylation of proline and lysine residues, these collagen molecules can get involved in cross-linkage formation. And these cross-linkage formation is responsible for the very high tensile strength of collagen. Okay, so prolyl hydroxylase and lysyl hydroxylase. So this hydroxylation of proline and lysine will happen as a co-translational modification of collagen. Okay, and after hydroxylation, few glycosylation also will happen on the polypeptide chain. So after they get synthesized as individual polypeptide chains, they reach the Golgi complex. Yeah, they reach the Golgi complex and they get secreted into the extracellular space. And when they get secreted into the extracellular space, all that they would have formed is a tropocollagen. What do you mean by tropocollagen? The collagen triple helix is organized like this, with an N-terminal end and a carboxy terminal end, which has not formed a helical conformation. Okay, so this is called as procollagen. So collagen is released from the cell into the extracellular matrix as procollagen. After it is released into the extracellular matrix, the terminals N-terminal end and carboxy terminal end will be cleaved off. After they get cleaved, that is called as tropocollagen. And these tropocollagen molecules will get organized in a quarter staggered appearance. What do I mean by quarter staggered appearance? 1/4 of every tropocollagen will be in alignment with 1/4 of the next tropocollagen. So this is called as quarter staggered appearance, and that adds more tensile strength. And after this quarter staggered alignment is done, comes lysyl oxidase. What does lysyl oxidase do? It converts lysine and amino acid into an aldehyde. And after you form an aldehyde, aldimine cross-linkage formation happens. And ultimately, after all these cross-linkages are formed, then it is called as a functional collagen. And this lysyl oxidase is dependent on copper. And that is why we know both copper and vitamin C are required for collagen maturation. Do you understand this? So what are the steps involved in collagen formation? I said collagen is a triple helix, and each and every one of those polypeptide chains gets synthesized separately, and they have 1000 amino acids. These 1000 amino acids are nothing but repetitive units of glycine XY. So the major amino acid that is present in collagen is glycine. They get synthesized by ribosome attached to endoplasmic reticulum. As and when the polypeptide chain grows into the vesicles of endoplasmic reticulum, hydroxylation happens with the help of prolyl hydroxylase and lysyl hydroxylase, which is dependent on vitamin C. After hydroxylation, these individual polypeptide chains leave endoplasmic reticulum and they reach the Golgi complex. In Golgi complex, glycosylation happens. Apart from glycosylation, triple helix conformation is also formed. Three alpha polypeptide chains will get oriented to form a procollagen. So they get released into the extracellular matrix as procollagen. What is the difference between a procollagen and a tropocollagen? In procollagen, the N-terminal end and the carboxy terminal end will be unwound. those unbound N-terminal ends and carboxy terminal ends will be cleaved off. That is when it becomes tropocollagen. And these tropocollagen molecules get aligned in a quarter staggered appearance. Then lysyl oxidase will oxidize it. That needs copper. That forms an aldehyde group, and that is involved in aldimine cross-linkage formation. That is when you get a mature collagen. Okay, so what is required for collagen maturation? You need both vitamin C and copper. Clear, Surya? The method which is used to study the tertiary structure of a protein is... What is the right answer? Tertiary structure of a protein is studied by, this is repeatedly asked, it is studied by X-ray crystallography. Okay, X-ray crystallography or UV spectroscopy or NMR spectroscopy. So what is the right answer here? The right answer here is X-ray crystallography. And about other choices, Sanger sequencing. Sanger was the first person to sequence protein, and the protein which he sequenced was insulin. Okay, and Sanger sequencing is used to study the primary structure of a protein. Optical rotatory dispersion is used for studying secondary structure of a protein. Reducing type of SDS page is used for studying quaternary structure of a protein. Okay, so now I am going to fill up this tabular column and will help you answer one-liners based on protein structure. Okay, so one-liners are framed based on the linkage that is present in all these structures and on the method that is used. And please remember, there are 5 levels of protein structure: primary, secondary, super secondary, tertiary and quaternary. Primary structure is nothing but amino acid sequence. And this is stabilized by which linkage, all of you? This is stabilized by peptide linkage. This is one of your doubts. Good. Okay. So amino acid sequence is stabilized by peptide linkage. Now, what is the method that is used for sequencing a protein? As I told you, Sanger sequencing, Edman sequencing. Yeah, Sanger sequencing, Edman sequencing and reverse sequencing. They can also ask you what is Sanger's reagent, what is Edman's reagent. So Sanger's reagent is 1-fluoro-2,4-dinitrobenzene. Okay, what is Sanger's reagent? It is 1-fluoro-2,4-dinitrobenzene. Edman's reagent is phenyl isothiocyanate. Okay, that's all about primary structure. Now secondary structure, I hope you all remember that we have 2 types of secondary structures. One is alpha helix, the other one is beta pleated sheet. Now what is the linkage which stabilizes secondary structure of a protein? It is hydrogen bonding. Yeah, what is answer? Secondary structure of a protein is stabilized by hydrogen bonding. To be very precise, alpha helix is stabilized by intra-chain hydrogen bonding. Beta pleated sheet is stabilized by interchain hydrogen bonding. Okay. Now, what are the methods used for studying secondary structure of a protein? It is optical rotatory dispersion and ocular dichorism. Yeah, optical rotatory dispersion and ocular dichorism. How can we memorize it? Secondary is 2 and you have 2 eyes, right? So optical rotatory dispersion, ocular dichorism, both have got something to do with eyes, right? So that is how I remember this. Secondary structure is studied by optical rotatory dispersion, ocular dichorism. Super secondary structures are also stabilized by hydrogen bonding. Tertiary structure is nothing but protein folding, and protein folding is stabilized by all non-covalent interactions. What are the non-covalent interactions? Starting from hydrogen bonding, van der Waals forces, electrostatic attraction, hydrophobic interaction. Yeah, among all these non-covalent interactions, if you are asked to choose only one, what will be your answer? Your answer should be, for tertiary structure, your answer should be hydrophobic interactions. Okay, hydrophobic interaction is the major force that stabilizes tertiary structure of a protein. And what are the methods used for studying both super secondary and tertiary structure? For both these, it's the same set of investigations. As I told you, X-ray crystallography, UV spectroscopy and NMR spectroscopy. And among these three, if you're asked to choose only one, your answer should be X-ray crystallography, because that's the most accurate method that is used for studying tertiary structure of a protein. Okay. Quaternary structure of a protein, it is stabilized by disulfide bridges. Okay, quaternary structure is, again, there is one MCQ that can be asked about quaternary structure. Not all proteins exhibit quaternary structure. Only those proteins which have more than one polypeptide chain can exhibit quaternary structure. And it is defined by how individual polypeptide chains interact with each other. For example, insulin can exhibit quaternary structure. Reason is insulin has got two polypeptide chains A and B connected by disulfide bridges. So tell me, what is the linkage which stabilizes quaternary structure of a protein? It is disulfide bridge. Okay. So can hemoglobin exhibit quaternary structure? Yes, because hemoglobin has got 4 globin chains. Can myoglobin exhibit quaternary structure? No, because myoglobin has got only one globin chain. Okay. Yes. So that's about a quaternary structure which is stabilized by disulfide bridges. Now, what is a method that is used for studying quaternary structure of a protein? It is reducing type of SDS page. Okay, quaternary structure of a protein is studied by reducing type of SDS page. So that's all about the 4 levels of protein structure. A quick recollection of all about protein structure. Primary structure is stabilized by peptide linkage. Method used will be Sanger sequencing, Edman sequencing and reverse sequencing. Secondary structure is stabilized by hydrogen bond. Method used is optical rotatory dispersion and ocular dichorism. Super secondary structure is also stabilized by hydrogen bond. And the method that is used is X-ray crystallography, UV spectroscopy, NMR spectroscopy. For tertiary structure, it is hydrophobic interaction. For quaternary structure, it is disulfide bridge. Method used will be reducing type of SDS page. Okay. So that's all for tonight. I hope we have covered most of the topics of biochemistry, and these are high yield topics which get often repeated in FMGE. So after the session, please revise all that we have discussed so far, and be confident in answering any case-based MCQ, because ultimately case-based MCQ would be a better way of, it would be better for you to answer, because there will be so many clues using which you will be able to exclude choices. Okay. So thank you. Good night.